Hello, I'm Dr. Shawn Dhillon. As a primary care provider in practice for over 15 years, I learned early the impact we can make in treating and managing dyslipidemia. My goal is to give you a better understanding of LIVALO and how it may be an appropriate choice for some of your patients with dyslipidemia. We'll review 4 key areas of clinical information for LIVALO: metabolism, efficacy data pulled from 3 pivotal trials, adverse reactions, and discontinuation rates. Let's begin by looking at the mechanisms by which statins are metabolized by the body. Approximately 75% of all drugs, including most commonly prescribed statins, are metabolized by the cytochrome P450 pathway. Because of this, co-administered drugs may potentially interfere with statin metabolism if they are also metabolized by the CYP450 system. LIVALO, unlike most commonly prescribed statins, is only minimally metabolized by the cytochrome P450 system, and because of this, may have reduced potential for clinically significant drug interactions. Let's review pooled efficacy results from 3 pivotal trials in which LIVALO was studied versus atorvastatin, simvastatin, and pravastatin respectively. With respect to LDL-C at the 4 mg dose, LIVALO demonstrated reductions of up to a mean of 45% across the 3 clinical trials. LIVALO 4 mg demonstrated mean reductions in non-HDL-C of up to 41% across the 3 trials. LIVALO also demonstrated reductions in other lipid parameters, including ApoB and triglycerides. Mean reductions in ApoB of 37% and 22% in triglycerides were seen with LIVALO 4 mg. Let's now review adverse reactions occurring in 2% or greater of patients treated with LIVALO and greater than or equal to placebo across short-term clinical trials of LIVALO lasting up to 12 weeks. At the recommended starting dose of 2 mg and the maximum daily dose of 4 mg, rates of adverse reactions were comparable to rates seen with placebo, except for myalgia, which was approximately 3% at the highest dose. Finally, LIVALO discontinuation rates due to adverse events were low at less than 4%, and were similar across all doses in controlled short-term clinical studies and their open-label extensions from 44 to 60 weeks. The most common adverse reactions that led to treatment discontinuation were elevated creatine phosphokinase at 0.6% with LIVALO 4 mg and myalgia at 0.5% with LIVALO 4 mg. Due to its non-CYP450 mediated metabolism, LIVALO differs from most commonly prescribed statins and may have reduced potential for clinically significant drug interactions. In 3 pivotal clinical trials, at up to a mean reduction of 45%, LIVALO demonstrated comparable rates of LDL-C to the commonly prescribed statins, atorvastatin and simvastatin, and statistically superior rates of LDL-C reduction compared to pravastatin. LIVALO also demonstrated reductions in other lipid parameters, including non-HDL-C, ApoB, and triglycerides. Rates of adverse reactions with LIVALO were comparable to placebo, and discontinuation rates with LIVALO were low at less than 4% and were not dose-dependent. In summary, in my professional opinion, all these attributes demonstrate that LIVALO is a potent and efficacious as well as safe statin option that offers reduced potential for clinically significant drug interactions. Thank you for taking the time to view this important treatment information.